Good afternoon or morning, everyone, depending on where you are watching me from. Thanks for joining us for a little class on postpartum hemorrhage and how to manage these patients. I think this is a very important patient that we need to be managing because these ones can be very challenging if we are not prepared for it. So I love to review these kind of ones. And obstetrics is one of my passions, and so I like to really talk deeply about these, so I'm looking forward to this. As you know, as you can probably tell, we're using a different type of technology today. We're using a new streaming service, and so hopefully you guys are excited about this. It gives a little bit more of a live production feel, so I'm looking forward to that. So please feel free to comment wherever you are. We're live on YouTube, we're live on Facebook, we're live on LinkedIn even, and then we're live on TikTok, and we're live on Instagram, and of course we are live inside our membership as well. So hopefully you guys are all excited about that. So before we get all started, I'm just going to make sure that everyone gets what they need here. So I wanted to make sure you guys are good to go. So thanks so much for joining me. I really appreciate it. It's always good to see everyone. And yeah, so let's see. Using the membership platform, fantastic. Where else are you guys from? Go ahead, put in the comments where you guys are at. I'd love to know. Go ahead and put it in the comments. Before we get started here, we're just waiting for everyone to kind of pile in here. So before we get started, we always are going to just get a little sound off. Where are you guys from? On board a ship in the Gulf of Mexico. That's awesome, Robert. From London, England. Where else are y'all from? Southern BC. Hopefully you guys are staying away from the fires. I'm going to be in BC next week, and quite a bit's going on there, and it makes me sad. What's up from Las Vegas? Right on. I was in Las Vegas in May. I loved it. Utah, Chicago, Italy. Where else? This is awesome. Montreal, Seattle, Jordan. I love it. Will we still get easier access on this new version? We will absolutely be getting you access for members, Josh. This type of streaming service is designed for what we need it for. And so we've been in talks for making this change for a little while. And so, yeah, it is absolutely going to make things a lot easier, a lot faster for our editor in order to get some of these productions done quicker for you as well. And it allows us to do some high definition stuff, so that way we can start to splice this up and actually put it into our interactive technology as well. So there's going to be a lot of really big benefits in using these, which is a lot less time wasted. So we're pretty excited about it. Ireland, Saudi Arabia, thanks for the meeting. Absolutely. From Italy, love it. Wow, thanks so much for joining me today on this class on postpartum hemorrhage. Now, this class is going to be about the case that we introduced this morning, which is we will kind of review it again here before we get into all of the craziness. And so that's what we're covering today, and how to manage this patient. So I think we've gotten everyone in, so why don't we get started? Okay. So for those of you that don't know kind of who I am, my name is Jeff. I'm the owner of Master Medics. I also am one of the lead educators with about a dozen other educators that work for Master Medics that are focusing on EMS education. Now, our bread and butter has been student education for years, and now we're really getting big into the specifically Canadian continuing education in order to really focus on giving back to those members that have trusted us with their initial education and now want to continue to work with us for their continuing education. And so that's where a lot of these cases are going to come from. And yeah, so that's what I am. So if you're interested, if you're in paramedic or EMT school, I highly recommend checking out a Master Medics subscription. It is free for the first 3 days. Check it out. See how you like it. If you love it, stay as long as you like it. If it's not for you, you can cancel anytime, no problem at all. But one thing that we have seen with our students, and we review a lot of things, get a lot of feedback from them, and our students reportedly consistently saying that they've been able to cut their study time in half as a Master Medics member. So that's a pretty fantastic thing that we're very proud of. And on top of that, if you are out of school and you are looking to get better continuing education, more advanced continuing education, and continuing education that actually makes you enjoy the learning process again, that's what we're committed to doing at Master Medics. So hopefully that's something that interests you as well. And it is on a yearly process that you just need to one up. And we're going to continue to pump out more live content, more recorded content, more interactive patient scenario stuff to make learning fun again. You can check that out at mastermedics.com as well. Okay, let's get into this case. You're dispatched to a private residence for a female patient who has just had a home delivery. You arrive on scene to find the patient in the bathtub. He looks quite fatigued and pale with a significant amount of blood in the bathtub. That's our case. There's a patient presentation down in the corner in the bathtub. And you're going to see, as you can see, there's quite a bit of blood that's still actively bleeding and quite a bit into the tub as well. So a pretty significant patient. Let's move into the vital signs. Okay, so heart rate is 136, blood pressure 73/46. I didn't have the ETCO2 on for this patient, but we would suggest that it was likely somewhere in the 28 range because of the low perfusion. SpO2, 83% currently with a poor pleth, and heart rate looks like it's in sinus tachycardia. Okay, so judging by the patient's presentation, they're fatigued, they're pale, and these vital signs, is this a patient that is pretty critical, or are we thinking not so critical? Go ahead and put it in the comments. What do you think? Are you thinking this is a fairly critical patient? What are you thinking? Shock? I agree. I think this patient is also in shock. Fairly critical. I would agree. Like our MAP is like 55. That's pretty critical. Our heart rate is high. Our SpO2 is low. We're looking at a pretty sick patient. And then judging by what we're seeing here as far as a shock perspective, this patient is in a decompensated shock. Okay, their compensation factors like their increase in heart rate, contractility, all those types of things that try and make compensation are failing, and we know that by the fact that our blood pressure is declining and it's no longer maintaining above a sustainable level. So this patient is in a decompensated state of shock. Okay, so for those of you guys that are still in school, one thing that often is going to be tested on is this hard limit of estimated blood loss. In a postpartum hemorrhage or PPH, the estimated blood loss that they're looking for is roughly over 100 or 500 mils. If it's over 500 mils, it's considered significant postpartum hemorrhage. Okay, and so if you are estimating that they've had that much of a loss, that's a water bottle. Okay, that's a water bottle of blood. If they've had over that, then they are considered a critical postpartum hemorrhage that needs to be controlled. Okay. So that's something to be aware of. There's always a little bit of blood when it comes to a delivery. That's your hard limit of when you should be concerned. Other things that'll help you know when you need to be concerned is looking at vital signs. Okay, in a patient that has that is just delivered and they have a little bit of blood loss because of this delivery, take some vital signs, see where they're at. Do they have an elevated heart rate? Do they have a decline in blood pressure? How is their mentation? How is their skin color? Looking for signs of shock can give you a good indicator of how much blood is lost. You're not going to see significant changes like this in a patient that's only lost 400, 500, 600 mils. You're going to look for these kind of changes when they have lost something like 600 to 1,000, maybe even 1,500, depending on how significant this bleed is. Okay, so when it comes to the reasoning for postpartum hemorrhage, there is 4 particular reasons that we see postpartum hemorrhage, and that is tone, tissue, trauma, and thrombins. And so tone is your most common. So tone is about tonicity or anatomy of the uterus itself. So when the uterus, when we deliver a baby, this uterus is relatively soft. It's not hard. And what it should happen after we go from intrautero with the infant to extrautero is that the uterus should harden. It should start to stiffen up and become hard. And when it doesn't, unfortunately, there's no constriction of those vessels. When we have that flaccid or anthony of the uterus itself, unfortunately, we do not stop bleeding very well. So this is the number one reason that we are going to see postpartum hemorrhage is a softness or a lack of tone in the uterus that needs to be dealt with. Okay. Then we have tissue itself. Okay, so tissue would be actually like a rupture of the uterus itself. This would be considered a tissue issue where we're going to have significant bleeding as well. A trauma is when there's an actual trauma. So think of it like an eruptional placenta type of situation. That's what we would be thinking from a trauma perspective. And lastly, a thrombin that potentially could cause significant bleeding as well. So these are what we call our 4 T's when it comes to causes of postpartum hemorrhage: the tone, the tissue, the trauma, and the thrombin. Okay, so as far as signs and symptoms, we've kind of already talked about this. The true way that we're going to be able to manage this patient or identify whether this patient needs to be intervened in and aggressively intervened with is if they have signs of shock, if they have a decreased mental state, if they have a significantly elevated heart rate, if they have a declining blood pressure, is their skin pale, do they continue to have active bleeding? These are all signs that we have a patient that is in shock that needs to be intervened with. So for bonus points, go ahead and put it in the comments. What type of shock would this patient be in? What type of shock is this patient in if they're in postpartum hemorrhage? What are your thoughts? What's the most common reason that we see shock? Or sorry, what's the type of shock that they are in? Absolutely. They're in a hypovolemic shock, hemorrhagic shock, blood loss shock. So if you can effectively treat this like a significant blood loss patient, like a traumatic blood loss patient, and think of it in that type of physiology, because that's really what's going on, is that we have a significant loss of fluid. That is classic hypovolemic shock. So that's how we're treating this, is that particular perspective. And that's going to come up and why we need to know that later in the treatment. Okay, so our treatment goals are twofold, pretty simple. Okay, 1, slow or stop the bleeding. 2, limit development of shock. Okay, these is as clear cut as the goals can get. So let's talk about slowing and stop the bleeding, because there's a few things that we can try and do. Okay, number 1, think of the basics. One of the things that can cause constriction of the uterus itself is a fundal massage. That fundal massage can start to stimulate a stiffening of the uterus that can start to help with contractions. So fundal massage is your basic first thing that you're going to do in order to try and stimulate contraction in that uterus. So that's the first basic thing. Don't forget it, because it's a useful thing. If mom is conscious enough and coherent enough, you could encourage her to breastfeed as well, which is going to release her natural oxytocin that could help with uterine contraction. Okay. The next thing that we can look at, and we should be looking at, is using oxytocin or Picotin. Oxytocin is a naturally occurring hormone that occurs inside the body. Sometimes the natural occurring or release of it is not enough in order to cause significant uterine contraction. But when we introduce something like 10 units of oxytocin into the body, into the bloodstream, IV or IM, which is most common, then we're going to introduce more stimulation of uterine contraction. Okay, that's what oxytocin does naturally in the body, and we're just stimulating a stronger response of it. And that's what oxytocin can do. So in postpartum hemorrhage, it can help that. Remember, entony, or the softness of the uterus, is the number one reason that we see postpartum hemorrhage. Okay, and so we need to, in order to slow or stop this bleed, the most likely way to do that is to stiffen that uterus. So fundal massage is going to do that, and oxytocin is going to do that. Okay, those are the two big things that are going to help stiffening of the uterus. Again, that's the number one reason that we see postpartum hemorrhage, is because of entony of the uterus, which is softening. Okay, next drug that has been controversial in pretty much all cases lately is TXA. TXA for the last 30 years has been kind of mainstay for postpartum hemorrhage. One of the first uses of TXA was postpartum hemorrhage. Now, there was a big trial called the Women's Trial that was conducted, and they suggested that there was a significant difference in patients that were given TXA and patients that were given placebo. The significant difference that they're talking about is about a 0.5 difference, okay? In the patients that were given TXA within 3 hours, okay, of delivery, the TXA group had a 1.2% chance of mortality, and the placebo group had a 1.7. Not a big difference, but something, okay? Keep in mind too, however, is that if TXA was given after that 3-hour mark, the mortality was actually higher. Okay, it was higher than the placebo group. So time is key when giving TXA. And so that's why it's very pertinent for EMS, because the earlier we give it, the more benefit we get from it. The later it's given, the worse outcomes we have compared even to placebo. Next thing that was tested is a need for hysterectomy. TXA and the placebo, identical, pretty much. In fact, TXA was a little bit higher. So is TXA a benefit in postpartum hemorrhage? Probably, possibly, maybe. And only if we give it within 3 hours, and ideally within the first hour, or as early as possible. The nice thing is that we know that there is no adverse side effects of TXA. So that's the nice thing, is that when you look at risk versus reward, the rewards, could be beneficial. The risk is low. Okay, so if we know that there could be a benefit and the risk is low, why not? Okay, and especially if it's within 3 hours, because we know that there is a possibility of benefit. Okay, so TXA is usually something that is brought into the equation when it comes to postpartum hemorrhage. Okay, so we've stopped that bleeding. That's what the fundal massage did. That's what the oxytocin did. That's kind of what the TXA did, is creating some clotting. So that's what we've done. We've achieved this goal, or we've started this goal. Now we need to get into limiting the development of shock. Now remember, this patient is in a hypovolemic shock. Okay? Hypovolemic shock. In these particular patients, what we're maintaining is the exact same. Maintaining a MAP of 65 or a systolic of 90. That's what we're trying to maintain. Now remember, hypovolemic shock, how well do patients do with fluids? Okay, just from a traumatic hypovolemic shock type of situation, how well do they do with fluids? Go ahead and put it in the comments. Are they a benefit? Or let's put it this way, are significant amounts of fluid a benefit to a traumatic hypovolemic shock? Sorry if it's lagging, I can't quite help that, unfortunately. Okay, hypovolemic shock. We know that the fluids are not a benefit. Okay, regardless of ringers or normal saline, ringers is better, but normal saline, as far as an isotonic fluid goes, not a benefit in hypovolemic shock. Okay, especially large amounts. So we're going to give fluids, because I know in EMS, blood is really not really in the equation in most places. So how much fluid should we give? And the answer is only enough to achieve a MAP of 65 or systolic of 90, depending on what your hard line is. Most monitors are actually more accurate on the MAP than they are on the systolic. Just keep that in mind. So a MAP, achieving a MAP of 65 would mean that you're actually achieving a MAP of 65. Okay, so that would be your benefit. That would be a benefit. Okay, if it's lagging on TikTok or Instagram, I saw a few people saying that it's lagging a little bit. Go check out YouTube, Facebook, LinkedIn. Those are the areas that it looks like it's not lagging. I don't think it is lagging on Instagram. It looks like it's just on TikTok. Okay, so using isotonic fluids, maintaining a MAP of 65 or 90 systolic. Now, here's a question that comes up is, do these patients require blood? And the answer is sometimes, okay? Do they require transfusion? It's likely, okay? Especially for seeing signs of significant shock. In fact, there is a rule of 30s that we can use in order to identify when a patient is going to need blood. And those rules of 30 are 30% fall in hematocrit. Fortunately, we can't really identify that in EMS. A 30% fall in hemoglobin, again, we can't identify that, and we don't have a trend to fall on. We don't have a hard line to fall on. But we can identify a 30 millimeter of mercury decrease in systolic blood pressure. Okay, and if you're like, well, I don't have a good blood pressure at first, okay, just take a average blood pressure for a 30-year-old female, between 110 and 130. Okay, so if you have a 30 millimeter decrease in systolic blood pressure from 110 to 130, or 110 and 120, that would be considered significant and likely needs blood transfusion. 30 beat per minute increase in heart rate. Okay, again, take your hard line. What's a heart rate in a 30-year-old female? Typically with no mobility or no issues, probably looking around 90 at the hard line. Okay, 90 to 100. Okay, we'll just call it that. So if you have a heart rate, in this particular case, we had a heart rate of 135. Is that a 30 beat increase from an average female if you don't have a trend to go by or a first set of vital signs that's normal? Yes, that's an increase, a significant increase, above 30. So if you have any things within the rules of 30, unfortunately, these are the two big ones we're going to use with EMS. If you have a drop of 30 in your systolic blood pressure from normal, or an increase in 30 beats per minute of your heart rate from normal, that would be an indication that this patient does need blood. Okay. Okay, so that is what we have for our postpartum hemorrhage patient. Any questions? Go ahead, put them in the comments. Any comments? Any questions? Let's come over here. Perfect. Well, I don't see any comments or questions that need to be addressed. But if you are interested in joining us for continuing education credits, please feel free to sign up for a Master Medics membership. Check us out. If it's something that you love or you love the education that we're providing, we would love to have you as a Master Medics member. You can get continuing education credits. We are CAPC accredited in the United States. We are accredited throughout Canada. We even give out international continuing education overseas as well. That's something that we're offering now too. So if you're interested in continuing education with us and you love the way that we teach, we would love to have you as a member. So you can check us out at mastermedics.com for continuing education or student education. So thank you so much for joining me today. I really appreciate you joining and taking the next 20 minutes in order to learn a little bit about postpartum hemorrhage. We will talk to you next week. Dean is going to be going over neonatal resuscitation. He has a lot of experience with neonates, and so I think that would be a fantastic class for you guys to check out next Friday when he does that. So thanks again for joining me. We will talk to you next time.